Hello and welcome to the Point of Care podcast. Today's episode is on sepsis and septic shock. As a background, for some history and definitions, in 1991, the SIRS criteria were introduced as a way to identify sepsis and patients at high risk of sepsis-related death. Sepsis was defined as the presence of 2 out of 4 SIRS criteria with evidence of infection. Severe sepsis was sepsis with organ dysfunction, and septic shock was if there was hypotension unresponsive to fluids. In 2001, Sepsis 2 expanded and clarified these definitions without a complete overhaul. However, the broad nature of SIRS criteria commonly led to misclassifications necessitating further revision. Between 2014 and 2016, the Sepsis 3 conference elected to eliminate SIRS and severe sepsis, instead introducing SOFA and QSOFA to identify sepsis in the absence of SIRS and to focus more on organ dysfunction, which narrows the spectrum of sepsis. Now, sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. Septic shock is defined as sepsis plus pressor need and lactate greater than 2 without hypovolemia, aka after you've already been resuscitated. The pathophysiology of sepsis includes an immune response to inflammation, which leads to vessel dilatation, capillary leak, edema, and intravascular hypovolemia, which then precipitates the extrinsic coagulation cascade and DIC, leading to microvascular thrombosis, tissue ischemia, and organ dysfunction and acidosis. When you're admitting a patient with concern for sepsis, here's a checklist and assessment. Start with your ABCs. See if the patient is hypotensive from hypovolemia and/or distributive shock, and decide whether or not the patient needs to be started on pressors. If they're in respiratory distress, try to decide if this is from pneumonia, ARDS, or hyperventilation from acidosis, and whether or not you need to intubate. You should also be thinking about whether the patient needs central access. For your chart check, look at prior culture data and the comorbidities that might increase the patient's risk for overload, hypotension, or an inability to fight off an infection. Also look for any recent procedures. For your HPI intake, ask about localizing symptoms, previous infections, recent antibiotic use, the presence of indwelling lines, sick contacts or recent travel, and the patient's immune status. Things that you can't miss include shock of any etiology and poor source control like an abscess or empyema. For your admission orders, for your infectious workup, make sure you send 2 sets of peripheral blood cultures, send a culture off any line that's been present for 48 hours or more, send urinalysis and urine culture, and get a chest x-ray. You should also send a lactate and in most situations, a procalcitonin. Initial treatments to consider include antibiotics. Start broad and narrow based on your source. Fluid resuscitation is commonly 30 cc's per kilogram of LR, but be very cautious not to overload the patient. You should start pressor if the patient is not fluid responsive. You should also consider the early administration of stress dose steroids if the patient remains hypotensive despite the initiation of a low to moderate dose pressor. For your exam, be looking for altered mental status, general appearance, and rigors. If they're hypotensive, look for a widened pulse pressure and a low diastolic pressure. If they have respiratory distress, look for tachypnea, decreased breath sounds, and crackles. Look for warm versus cold extremities, mottling, capillary refill, rashes, and any evidence of cellulitis. Check for right upper quadrant pain, signs of peritonitis, and CVA tenderness. For your etiology and differential for sepsis, pulmonary sources include pneumonia. Urinary sources can be UTIs, pyelonephritis, or an infected stone. Gastrointestinal causes can be cholangitis, C. diff, appendicitis, diverticulitis, obstruction, or a perforation. Skin and soft tissue infections can be caused by toxic shock or necrotizing fasciitis, leading to sepsis. CNS causes can include meningitis or a spinal abscess, Bacteremia can be from line infections, gut translocation in neutropenic patients, and endocarditis. Other infectious etiologies can be tick-borne, including anaplasmosis, Candida, Aspergillus, and PJP. Some mimics that might appear like sepsis include acute mesenteric ischemia, bowel obstruction, pancreatitis, liver failure, decompensated cirrhosis, adrenal crisis, thyroid storm, and DKA. For your plan for working up the patient, for labs, you should follow up the infectious workup that you send off, including a procalcitonin, and consider sending off fungal markers like 1,3-beta-D-glucan, galactomannan, or a cryptococcal antigen if you have concern that the patient might have fungemia and is at risk. For your imaging, start with a chest x-ray, but you should consider getting cross-sectional imaging with a CT chest, abdomen, pelvis to identify a potential source if you're not sure what's happening. You should be monitoring daily CBCs, CMPs, coags, and have strict eyes and O's to monitor the patient's urine output. For your treatment, empiric antibiotics should be vancomycin plus a beta-lactam backbone, usually cefepime or piptazo. This is to cover for gram-negatives and gram-positives, including Pseudomonas and MRSA. If there's concern for toxic shocks or Fournier's gangrene, add clindamycin. Tailor this to your clinical presentation, resistance pattern, and any previous culture data. For volume, you should note how much volume the patient's already gotten in the emergency department, and you should have an idea of how much more you're planning to give. Just be cautious not to overload the patient. For pressures, you should titrate to a MAP goal of greater than 65 in most circumstances, and will most commonly start with norepinephrine, but other options include vasopressor and epinephrine. Phenylephrine might be a good option to increase afterload in patients with AFib or aortic stenosis. For steroids, it's hydrocortisone 200 milligrams daily, usually given in divided doses of 50 milligrams Q6 or 100 milligrams Q8, and this is usually in the case of refractory shock. Make sure the patient's on oxygen and titrate as needed for a goal, usually above 94%. Other things to be considering is whether the patient needs transfusions, dialysis, or bicarbonate. For some clinical pearls on the etiology, pathophysiology, and complications, pneumonia is the most common cause of sepsis. Gram-positive bacteria are more common in the United States, but gram-negative sepsis tends to make patients sick faster. Significant clinical complications of sepsis to be on the lookout for include vasodilatation, ARDS, cholestasis, AKI, hepatic dysfunction, and DIC. Gram-positives have exotoxins and superantigens, and GNRs have lipopolysaccharides. Good urine output is overall reassuring in sepsis, but low urine output is nonspecific. Risk factors for fungemia include neutropenia, chemotherapy, transplants, and indwelling lines. Some pearls for the laboratory values in sepsis. Lactate elevation is most commonly attributed to hypoperfusion and is viewed as something that needs to be rapidly corrected. However, lactate may be more appropriately thought of as a reflection of endogenous epinephrine production, and persistent or worsening elevation may prompt you to rethink the source of infection, your antibiotic selection, or if there's another diagnosis entirely. The differential for lactatemia includes type A, caused by tissue hypoxia, which can be caused by hypovolemia, shock, localized ischemia, including mesenteric or limb ischemia, decreased oxygenation, anemia, and increased metabolic demand, like seizure, rigors, or exercise. Type B lactatemia, which is not caused by tissue hypoxia, can be caused by an increased adrenergic state, like albuterol, cocaine, epinephrine, or pheochromocytoma, a decreased Krebs cycle caused by thiamine deficiency, alcohol use or cyanide toxicity, and liver dysfunction, which can lead to decreased gluconeogenesis and reduced clearance. The neutrophil to lymphocyte ratio, or NLR, can help identify patients with early physiologic stress due to endogenous cortisol and catecholamines, which mobilize neutrophils and kill lymphocytes. If the ratio is 6 to 10 or more, it may suggest clinically relevant stress warranting closer monitoring. Procalcitonin is a measure of inflammation that is sensitive to bacterial pathogens, most notably gram-negatives. It's been investigated for the purpose of identifying patients unlikely to have a bacterial infection and de-escalating antibiotics in the ICU setting. However, it can reasonably be used in patients who are already started on antibiotics with normal immune systems who have a presentation equivocal for sepsis. If the procalcitonin is less than 0.5, it's less likely to be sepsis or septic shock, noting that it can take a day or so to become elevated. For pearls related to resuscitation and fluid management, some suggest that the goals of resuscitation are to clear your lactate, return the capillary refill to less than 3 seconds, and improve hemodynamics and urine output. However, be wary of misinterpreting the etiology of lactate elevation and assuming poor urine output is due to prerenal AKI instead of intrinsic ATN from sepsis, as it may lead to inappropriately overloading a patient. The focus should be on ensuring tissue perfusion. Hypovolemia is not the core problem in sepsis. Rather, it's vasodilatation and poor perfusion from poor distribution of blood to vital organs. However, many patients with sepsis will present with hypovolemia and benefit from fluid resuscitation to achieve euvolemia. A great deal of administered fluid may likely leak out of vessels in sepsis. Unless there's a compelling clinical reason to suspect otherwise, giving more than 2 to 3 liters of fluid is unlikely to help and may even cause harm via overload and pulmonary edema. In general, MAP is the most reliable parameter for assessing response to therapy. The primary concern with low MAP is renal injury. A fluid challenge of 250 to 500 cc bolus can be utilized to see if further fluid might be beneficial. However, note that the common ways we measure fluid responsiveness should be taken with a grain of salt. A passive leg raise can be done instead of bolusing. You raise the legs to 45-degree angle for 1 minute while the patient lies supine, and you watch their CVP and MAP, because this is the equivalent of giving 250 to 350 cc's of venous blood return. Some prior work suggests that an adequate fluid challenge is if the CVP increases greater than 2. The IVC diameter collapsibility of less than 50% with inspiration might also suggest that the CVP is elevated. For some pearls on vasopressor selection and use, usually start with norepinephrine or Levophed as the initial pressor. Norepinephrine can be administered peripherally, but prolonged use can lead to increased risk of extravasation, which could lead to necrosis. You can consider adding vasopressin when the Levophed dose reaches 5 to 15 micrograms per minute, or in patients who are tachycardic or at risk for arrhythmia. Vasopressin is usually considered either on or off. It should not be used peripherally. Epinephrine is typically the third agent introduced, especially when Levophed exceeds 25 micrograms per minute. It may be especially beneficial in patients with reduced EF, inappropriately low to normal heart rate, and note that epinephrine infusions will increase the patient's lactate. Phenylephrine, or NEO, is chosen for increased afterload, particularly when Levophed causes side effects like arrhythmias or in cases of AFib with RVR and hypotension, provided the cardiac output is satisfactory. Dopamine is not commonly used, but can be considered for patients with bradycardia who are at low risk for arrhythmias. And methylene blue is a rare choice reserved for suspected vasoplegia. For pearls related to acidosis management, in the cases of severe acidemia with a pH less than 7.1, which can lead to myocardial depression, decreased pressor efficacy, and increased arrhythmias, you can consider using bicarbonate. This is especially true if there's significant AKI. Bicarbonate can be administered as a 50 ml equivalent per 50 ml ampule or as an infusion with 150 ml equivalents in a 1 liter of D5W. Just note that administering bicarbonate increases the PCO2 levels, which the patient must ventilate off. Ensure the patient has a strong respiratory drive or be prepared to potentially intubate them. early dialysis initiation has not been shown to have consistent benefits unless there's an urgent need, remembered by the acronym AEIOU. For pearls related to steroid use in sepsis, the use of steroids in sepsis remains a topic of debate. However, for septic shock, in patients refractory to low to medium doses of pressor, they may benefit from IV hydrocortisone at doses of 50 milligrams every 6 hours or 100 milligrams every 8 hours. The treatment typically lasts 5 to 7 days, followed by a taper based on the patient's response. Fludrocortisone is unlikely to add any additional benefit. The body naturally increases cortisol production during stress, including severe infections like sepsis, as a defense mechanism against inflammation and to maintain cardiovascular stability. Some septic patients might experience relative adrenal insufficiency or critical illness-related corticosteroid insufficiency, where the adrenal glands don't produce adequate cortisol. And that's why steroids can be valuable. Contraindications to steroid use might include immunocompromise, fungal infection, or poorly controlled diabetes. If you remember nothing else, remember that sepsis, which is a condition with evolving definitions over the past number of years, can manifest in various ways. While the SIRS criteria are sensitive in detecting sepsis, they lack specificity. On the other hand, QSOFA offers greater specificity, helping clinicians discern common patterns among presentations. When suspecting sepsis, it's imperative to obtain cultures promptly and initiate broad-spectrum antibiotics without delay. While initial fluid resuscitation is crucial, it's equally important to monitor for signs of fluid overload, such as deteriorating oxygenation and respiratory status, which might hint at pulmonary edema. Should the patient's response to fluids diminish, or if they remain hypotensive despite fluid resuscitation, do not delay in introducing vasopressors. Norepinephrine is typically the first choice in sepsis or undifferentiated shock. Continuous monitoring remains at the heart of sepsis management. Aim to maintain a mean arterial pressure between 60 to 70 millimeters per mercury and ensure urine output of at least 0.5 mils per kg per hour. Track the serum lactate levels along with other relevant lab results, which provides valuable insights into the patient's response to the treatment. Identifying and addressing the source of infection is paramount. This may involve surgical interventions, abscess drainage, or the removal of infected devices. If there's no improvement in the patient's condition or if they show signs of deterioration, it's time to have a thorough reevaluation. This includes revisiting the initial diagnosis, searching for other potential sources of infection, verifying the suitability of the current antibiotic regimen, and being vigilant for complications or nosocomial infections. That's all for this episode. Check out pointofcaremedicine.com to see the templates we discussed, as well as the pearls, literature, and links to other resources.